Hello friends, I'll continue my discussion about lipid. Today I'm talking about part 2, but before that I already have taken part 1 where I discuss all the basic concept about lipid. If you have not seen that lecture, I'll sincerely request you to see first that lecture because it is the continuation of the previous lecture. If you have not seen, then you may have little difficulty in understanding this lecture. But again, reminding you, lipid is considered as one of the most difficult topic, but I'll try to make it as simple as possible. So let's talk about fat digestion and transport. Well, fat in the diet is in the form of triglyceride. One point that you should know very well. It does contain a little bit of cholesterol also, but otherwise, unless specified, dietary fat is triglyceride. Now, this triglyceride, as discussed in the part 1 lecture also, this is converted into free fatty acid and glycerol. This is done by the pancreatic lipase, what we write as PL. The simple lipase that we read in our school days also, we know that in the pancreatic juice we have a amylase, we digest carbohydrate lipase. This is the same thing, but I am writing as pancreatic lipase because there are many other type of lipase which I discussed in the previous lecture, part 1 also. Anyway, fatty acid and glycerol are being made in the intestine, right? So here is the intestinal lumen. In the lumen, what is made is free fatty acid and glycerol, G for glycerol. And now they are absorbed into the intestinal cell. So the free fatty acid and the glycerol, they have come to the cell of the intestine. Free fatty acid, I am writing F and G, again for easy, F for fatty acid, free fatty acid, G for glycerol. They are again unite. They unite to make triglyceride. Oh come on, triglyceride, fat. It came as triglyceride in the diet, broken down, enter as a broken down, but in the again they unite to make triglyceride. So triglyceride is there, but it is a fat. It's not a water soluble, so it cannot enter into circulation. So now this is made water soluble by adding apolipoprotein B48. So B48 get attached to this, and that make a chylomicron, right? Now little bit of a word about apolipoprotein. These are the one which coat the lipid and they make it water soluble. Well, I can give you day-to-day example. Day-to-day example, you want to go somewhere, you are at home and you plan to go out, suddenly huge heavy rains come. Now if you go out like this in the rains, you will totally become wet. So what you do? You take a raincoat. You take raincoat, you put on raincoat and then you can walk comfortably. Rains are there, but you are walking without any problem. You are not getting wet at all. Why? It is the raincoat which is saving you from the rains. Exactly same thing. It is B48 which is covering the triglyceride which is in the form of chylomicron. Now it can enter the circulation. So friend, in this keyword, that remember, remember B48, you have to remember it. Okay, so little bit more about. So as I told you, all lipoproteins fraction must be coated. We have all lipoprotein must be coated by apolipoprotein to make it water soluble. By, right sir? So now this newly made chylomicron, newly married, this newly married or newly become friend, this chylomicron has come to the circulation. Chylomicron B48, it is just like a fresher. It's just like a fresher which enter the medical college. Okay, well, this is a newly made, also called, the word using nascent chylomicron. So when it come, its seniors meet, and now it get attached with, and of course, this enter the, it is the intestinal cell. It is in the intestinal cell. It will enter the lymphatics. From lymphatic, ultimately it will come to the blood vessel. From lymphatic, ultimately it will come to the blood vessel. Okay. So intestinal cell, lymphatic and blood vessel in the form of what? Nascent chylomicron. And what is being covered? Which molecule is covering? B48. Agreed. Apolipoprotein B48 is there. It has come to circulation. Now what happened in the circulation form? Okay. So we talked about chylomicron. So before I discuss a little bit more about what happened to chylomicron, a brief word. Chylomicron is made from dietary triglyceride. Yes. Now why I'm writing this line? It will be absent during fasting. Very, very important line. Why? Because it has to be made from the dietary triglyceride, right? And if the patient has not taken for anything for 12 hours, then there is no chylomicron, there is no fat in the intestine, nothing digested, so no chylomicron. This is a worth $1 million line. This is absent in fasting. But what the need to lay such an important stress on this line? Let's take a practical point. You ask a patient that, okay, in the morning you come fasting, I want to take your sample for lipid, and for lipid fasting is for 12 hours. For glucose we take 8 hours fasting, but for lipid we take 12 hours. There are 2 points that you got to remember. Now you take a sample, and in the sample you find a lot of chylomicron is there. So now you can very well say that this patient is cheating us. He didn't come fasting because it contains chylomicron. So under normal situation, chylomicron should be absent in the fasting state. But there is some pathological condition where chylomicron can be there. What is that? That I'll be talking to you in the coming slides. Okay. Now what's the composition of this chylomicron? It contains 87% is triglyceride. It contains cholesterol 3%. Point to be noted what I was talking to you. That dietary fat is mainly triglyceride. Little bit of cholesterol is there. Okay, so it means when we want to talk about cholesterol, then in the fasting state, in the chylomicron, only 3% is there. It has a lot of relevance. I'll be talking to you in the coming slides. It contains protein 2%. It contains phospholipid 8% also. This all is so-called chylomicron. The major shareholder is triglyceride. With this background of chylomicron, what it was, it has come to lymphatic. From lymphatic, it has entered the blood vessel, which is a nascent form, so-called new fresher in the medical college. So when it come to the medical college fresher, this is the blood vessel. Here is the chylomicron. It has 87% of triglyceride. B48 is the one which is there with him, and now it come to into the blood vessel. In the blood vessel, it meets its new friends. The one friend is apolipoprotein C2. I'm writing C2, it is ApoC2, apolipoprotein C2, and apolipoprotein E. I'm writing E. So apolipoproteins C2 and E get attached. Now we call them as mature. chylomicron. Before that it was immature or nascent. But from where these two apoproteins, they come from HDL. Very, very important point. This again I'll be talking to you in great detail, but as of now, make the basic concept very clear. It is HDL in the blood which is giving to C2 and E, and ultimately now it make a mature chylomicron. If you recall, in the previous lecture I told you this triglyceride in the chylomicron is broken down into free fatty acid by lipoprotein lipase, and it makes chylomicron remnant. I hope you remember it. Yeah. So now I'll be talking again to same thing. So this triglyceride in chylomicron is hydrolyzed by capillary lipoprotein lipase. What we write as CPL. Capillary lipoprotein lipase into free fatty acid and glycerol. One thing is very clear, triglyceride is made from fatty acid and glycerol. It is broken down into fatty acid and glycerol. And so whatever left is chylomicron remnant, which goes to what? It goes back to the liver, where and these fatty acid and glycerol, they can also go to liver and can make triglyceride in the liver or in adipose tissue. Remember, in the first part when I told you, site of triglyceride synthesis is either the adipose tissue or the liver in the body. And of course, I did mention about memory body also in the lactating ladies, of course, but that is an exceptional case. But for all practical purposes, this is synthesized in the liver and the adipose tissue. Adipose tissue is the storage site for the fat. Now this capillary lipoprotein lipase, which is in the circulation, break down some amount of triglyceride in the chylomicron, and what makes is chylomicron remnant. Okay, and definitely it contains less triglyceride, the point I mentioned previously, because I gave example of 100 molecule of triglyceride were there, 20 were broken down into free fatty acid. So chylomicron contain 80, less amount of triglyceride in as compared to mature, and this can now this again go back to the liver. Now this was broken down by capillary lipoprotein lipase, CPL, and this is now who makes insulin. Now CPL are made by insulin in the fat state. Can you think of why I especially wrote in fat state? Because normally in the fasting stage there is no chylomicron. No chylomicron means CPL is not needed. The God is the greatest engineer. Just see how beautifully the God has made our body. When this chylomicron enter the blood, when we need CPL, then the insulin, again we know very well that after when we eat food, the level of insulin goes high, and that lead to more and more CPL formation, and that lead to more and more that break down the chylomicron. Now this CPL is located in capillary in the adipose tissue, muscle, and the myocardium also. 3 places, point to be noted. Adipose tissue, muscle, and the myocardium. Well, so again chylomicron, we have C2, we have E, and we know that it is to be broken down by CPL. Now this gentleman CP2, which is there in the mature chylomicron, it is this which will stimulate CPL. Very interestingly, so now one part of mature chylomicron C2, it will stimulate CPL. CPL was made by insulin, but it is stimulated. He says, come on CPL. Oh, it is creating a kind of energy in the CPL in a very lighter way. I'm saying, get activated, come on. It's just like a boxer fighting, and you are supporting a boxer A. He falls down. He's down in the ground. What you say? Come on, A, Mr. A. He create energy, and now the boxer A stand up and start fighting. They start fighting by ApoC2. And now it will activate it, and it will be chylomicron remnant, which contain lesser amount of triglyceride. It has C2, it has got E also. Now this chylomicron will come back to the liver. In the liver we have a receptor for E receptor is there. And now with this E apolipoprotein, it will enter the liver. Because there are receptor for the E. So when the chylomicron remnant come to the liver says, okay, now it will enter via E. Liver says, come on, chylomicron remnant, come on. And for you, the gate, E receptor E is there to receive you. Mr. E receptor come and receive, and this how the chylomicron remnant goes to the liver. The most simplified way of presentation to you. So in quick recap, ApoC is responsible for activation, and it is ApoE, which is for which there is a receptor in the liver, it enters the liver. So we are very clear about dietary fat. A quick recap: dietary fat in the intestine, free fatty acid, glycerol, both enter the intestinal cell. They are again make triglyceride packed into chylomicron B48. They come to circulation. C2 and B ApoE get attached. C2 will activate CPL, which will break down this chylomicron into chylomicron remnant, and this chylomicron remnant will come to the liver, get attached to the E receptor for E via ApoE, and it enters the liver. This simplified version. Now VLDL. So ultimately liver is getting lot of chylomicron remnant which has triglyceride also, and fatty acid and glycerol are also coming to from the circulation to the liver. The liver has a good resource of fatty acid and glycerol. Now again in the very beginning I told you that this liver itself synthesizes triglyceride, and this is known as VLDL. So triglyceride in the liver is in the form of, again, it's 3 fatty acid and 1 glycerol. Everywhere 3 fatty acid with 1 glycerol, 3 phosphate. Okay. So now the triglyceride is packed into VLDL, and it is secreted in the blood as a nascent VLDL. Point to be noted, even chylomicron when enter the blood was immature and nascent. It is also nascent, or you can say again a fresher in the medical college. The way you all have been fresher, I was also a fresher one day. So you are a fresher. This fresher come to the circulation. So this the VLDL in the blood, it get attached to ApoB100. So now it is so it will be packed with B100 and goes to B100 goes, and now it can flow very freely into circulation. Remember, it is made water soluble by immediately the moment it is the liver, it get attached to B100, and now it can freely go into the circulation. Now this VLDL, which has been packed by B100, what does it contain? It contains triglyceride 55%. Point to be noted, in chylomicron it was 87%, but it has got 55, lesser than chylomicron. Protein 9%, there it was 2%. Cholesterol 17%, there it was 3%. And phospholipid is 19%. So triglycerides is less. So let me show you a lovely picture of the lipoprotein. In lipoprotein, we have one is the central portion and other is the surface. You can see. Now a closer look of this. Closer look. In the surface, we have a cholesterol, and we have a single layer of phospholipid. Well, in the center, we have a triglyceride, fatty acid and cholesterol ester. Three things are there. Free fatty acid, triglyceride and cholesterol ester, they are inside the cell. Okay. Now look into this. This is a sample taken for the lipid. If you can see, this is the blood. All the cells have settled down in the bottom, but in the upper you can see all milky. You all have, say, you know that when we take a blood, that the blood cells settle down and the upper part is plasma, which is usually clear but it's totally turbid. So you can see turbidity in the plasma. This is due to chylomicron or VLDL. Well, what are these? They are triglyceride. They are triglyceride. So VLDL is there, or triglyceride, chylomicron or VLDL, right? But this again I'll be using in when I discuss the lipoprotein disorder. I'll be using this slide. So by and large, we learned the VLDL is again a source of fatty acid and glycerol. Subject has become very easy for you. And I also told you it is CPL, capillary lipoprotein lipase, which will break down into fatty acid and glycerol. Okay. So when we break down VLDL, it gets converted into IDL by CPL. Now this IDL produces LDL. The slide, if you want, I can go back to the original slide. Original slide, what we discussed was like this, a quick recap. Oh, it was in part 1, I suppose. Yeah, it was in part 1. That's why I said if you have seen the part 1, the things become very easy. Okay. Yeah. VLDL, IDL, LDL. Some of the LDL is removed by the blood by ApoE receptor in the liver. This goes to the liver again by ApoE. Now, cholesterol ester transport protein CETP. At the end of the first part, I mentioned to you regarding LCAD and CETP. So let's talk about CETP. Its function is to transfer cholesterol from HDL to VLDL. Very, very important point. If you recall the last slide of part 1, I told you from HDL, cholesterol is transferred to VLDL and other places, all done by CETP, the same thing. It transports triglyceride from VLDL to HDL. Oh, come on. So we have VLDL and it take cholesterol to HDL. Okay. It take cholesterol from HDL. It take cholesterol from HDL to VLDL. But it take triglyceride from VLDL to HDL. So it's a nice exchange phenomenon. VLDL say, give me cholesterol. Then HDL say, what will you give me? He say, I'll give you triglyceride. In other way around, the exchange process going on, right? So ultimate the aim of, in fact, what happened, aim of HDL to collect cholesterol from the peripheral tissue. It takes cholesterol from peripheral tissue. HDL takes it. So HDL doesn't want that cholesterol should be there in the peripheral tissue. That's why if the local HDL is there, this cholesterol in the peripheral tissue will not come back, and that cholesterol will stay in the peripheral tissue. Peripheral tissue primarily is the site for atherosclerosis. That's why when HDL is deficient, more cholesterol will be there more in the peripheral tissue. That will lead to atherogenicity. Got it? Well, so ultimately when the HDL get cholesterol from peripheral, now the purpose of HDL to get cholesterol from peripheral tissue to the liver. In the liver, it goes into bile or synthesis of the bile acid. Point to be noted, bile has cholesterol, bile has bile acid and salt is there, right? So we learn what is happening to the cholesterol and what the role of HDL. Now, when excess of VLDL will be there, okay? Excess amount of VLDL getting synthesized, the cholesterol will be coming to this place, the HDL cholesterol will go down. Definitely, more and more VLDL getting made, more and more cholesterol will be transferred to the VLDL. In the cholesterol level in HDL will go down. So with increase in VLDL always cause a decrease in HDL cholesterol. So that's why this VLDL is a risk factor for coronary artery disease, because this also can get deposit into the coronary artery. How and why, this I'll be talking to you in the next lecture. But as of now, one thing, only carry home message for you is HDL cholesterol bring cholesterol from peripheral tissue to it eats peripheral cholesterol, and this cholesterol it take to the liver, which it goes out. So peripheral cholesterol taken by HDL goes to liver, and liver it goes into bile or bile acid. But if VLDL is getting made more, then more and more cholesterol will be transported to VLDL. So HDL cholesterol will be reduced, definitely, right? And how and what is going to have effect, that I'll be studying in the coming lectures. Now, how to calculate VLDL level? So whatever triglyceride is there, you divide by 5, that is VLDL. So VLDL is triglyceride divided by 5. So we can also say triglyceride is 5 multiplied by VLDL. VLDL. Simple. Triglyceride is 5 times of VLDL. Now we talk about applied biochemistry, clinical side. How much the optimum triglyceride level should be there? Optimum level below 150 mg/. But we say borderline high level when level is between 150 to 159. So below 150 to 199. Then high level is 200 to 499. And the value is very, very high, we say, when the value is more than 500. These are of course, very high level of this is going to happen. What will happen, that I'm going to discuss in the coming slides. Now, I show you a test tube where I showed you the turbid plasma. What are the cause of increased plasma turbidity? One was anything due to milk. Now remember, turbid means milky appearance of the plasma. It is due to very high level of triglyceride, maybe as high as more than 1000 milligram. Remember, normal level was below 150, which I discussed in the previous slide. So turbidity may be a high amount of triglyceride. What we say very high means more than 500, and it may be, remember, the triglyceride level may be as high as up to 1000 milligram also. Now, in the increase in triglyceride, the two sources, either chylomicron or VLDL. either chylomicron or VLDL. This now you can answer this word very comfortably, because you know the basic source from where that this triglyceride is coming. This is coming from diet, this is coming from the liver. So this is so either the patient, if you are getting turbid plasma, that means either he is not taken fasting or there is increased synthesis of VLDL. What is that? We'll talk about it. So now again come back. Turbidity, increased chylomicron or increased VLDL, or because of increased triglyceride. So now what we do? We know it can be from the diet, or it can be from the liver. So what we do? You take a blood sample like this, and you take it and you keep in the fridge, refrigerator, in the upright position. Okay. You leave the tube in the upright position. It is standing like overnight. You leave it. Let it settle down. In the morning, you open the fridge, you take out as it is, you take out that bottle. So, now why we are keeping it, gives a triglyceride to settle based on how much is the density. Okay. So now in the morning you find milky material is floating on the surface of the plasma. It is chylomicron is increased. Okay. Let me give example. This is the test tube or tube where it contains blood. This much is the blood. Blood cells are there. Now we have plasma. And now we have this layer, turbid material. So this milky material is floating above the plasma, above the red cell or the blood cell, where I'm written R means blood cells to be more precise. So we are getting 3-layer plasma cells and the milky layer. This is due to chylomicron. It means patient did not come fasting. You can, looking at a tube only, you can say, oh, this gentleman did not come fasting. That's why we are getting like this. Okay. So either he has not come fasting, but there is one more condition. Patient has type 1 hyperlipoproteinemia. Don't forget these 2 lines. Okay. So friends, if you are getting, this is known as supernate. This is known as supernate. If supernate is there, that means either type 1 hyperlipoproteinemia is there, or he has not come fasting. This the not coming fasting is the most common cause. Now if the milky material is dispersed throughout the plasma, what is this? Let me give you. Same tube, we have a tube, we have a blood cells, which are settled down, and now we are getting this layer, only 2 layers. In the previous one we got 3 layers. This is common in both, but here it was the plasma and the supernate. But now we have this mix, that means that lipid and plasma are mixed, or you can say the lipid has been dissolved into the plasma. If you are getting like this is known as infranate. This VLDL is increased. So that means if you look into these 2, by looking only at the tube in the morning, you can say whether it's a chylomicron or type 1 hyperlipoproteinemia there, or it is a VLDL is increased. Now VLDL is increased in type 4. So if you leave aside the fasting, we presume the patient is fasting. This indicates type 1 lipoprotein disorder, and this indicate type 4. This I'll be discussing in the coming lecture. Now if both are present, something very interestingly, you are getting mix also, you are getting cell also, and you are getting supernatant also. Come on. And you are getting supernatant also. Very interestingly, third scenario, this indicate type 5 hyperlipoproteinemia. That means just looking at the tube in the morning, you can decide type 1, type 4 or type 5 is there. Lovely basic concept. Now we talk about low density lipoprotein. A quick recap, we got VLDL, this get converted to IDL, this can convert to LDL, or it can go back to liver. So now let's talk about LDL is there. So this one. It transports mainly the cholesterol in the blood. It derives from the hydrolysis of IDL by CPL. CPL is involved here, CPL is involved here also. Okay, or it can be removed in the liver by a LDL receptor. Okay, it can go back to the peripheral tissue. It can go back to the it can be removed from the blood by LDL receptor. LDL receptor in the peripheral tissue. This is the peripheral tissue, PT, and it is by LDL receptor is there, and finally it will go to the peripheral tissue. So this how LDL, which start from VLDL, IDL, LDL, and it goes to the peripheral tissue and get deposit there. Okay. Now we have one more molecule, so-called small dense LDL. The previous section we talked about LDL. Now we talk about small dense LDL, and it is this which are increased risk of atherosclerosis. The reason being, they are small size particle. So these dense LDL, they are small size, and they are one which get deposited into the endothelium, because they can very well penetrate into the endothelial lining. So what is the composition of this? It contains 10% triglyceride. Point to be noted, very less amount. Cholesterol 47%, that's why it got deposited in the peripheral tissue. Phospholipid 20 and protein is 22%. But triglyceride is only 10%, more of a cholesterol. Now how we calculate LDL? Total cholesterol divide minus HDL minus triglyceride. Divide by 5, or you can say we want to use VLDL. So cholesterol minus HDL minus VLDL. VLDL, and how we got VLDL value? Triglyceride divided by 5, which I mentioned previously. So this how we get LDL cholesterol is there. Okay, right? Now what are the function of cholesterol? Very important. Major component of cell membrane I mentioned to you. Vitamin D, adrenal cortex, sex hormone, androgen, estrogen, cortisol, and bile salt, bile acid in the liver, the point I mentioned. So ultimately now you are clear about it, about triglyceride and cholesterol, what happens. Now what is the clinical important LDL level? Up to 100 milligram is a normal, but if it is more than it becomes a risk factor for CAD. They are the risk factor for CAD. This is normal, optimum level. So near normal level, 100 to 120, the risk of CAD is minimal, low. 130 to 159, moderate. 160 to 180, moderately high. And above 190 is very high risk factor for the CAD. Point to be noted, higher the risk of cholesterol, higher is the risk of coronary artery disease, and optimum level is less than 100. Right? So Now, what are the risk factors which are included for CAD? Age more than 45 and female more than 55. Very, very important line. That means coronary artery disease is more common in males. Now, premature history of CAD, this again a very, very important point. When do you say? Now, in the family, if a female develops coronary artery disease below the age of 55 or a male develops coronary artery disease below 45, then we call as premature history of CAD in the family. Okay. Or LDL more than 160 milligram, what I mentioned in the previous slides. Current cigarette smoking, this is important. This needs description. Patient come to you. Do you smoke? Yes, doctor, I used to smoke long back, but I left for 10 years. That 10-year history is not even now that important to contribute to CAD as compared to a person says, yes, doctor, I smoke. Yeah, I smoke 10 cigarettes a day. The current cigarette smoking is much more important than the past history. BP, any degree of hypertension is predisposed to CAD, and low HDL. Why? Because low HDL is the one which takes cholesterol from the peripheral tissue, picks up HDL and take to the liver. Take to the liver, and that's why a high, so HDL is a good cholesterol. It takes the peripheral cholesterol which are deposited in the peripheral tissue, or I can say it is a scavenger. It scavenges peripheral cholesterol, bring back to the liver and either goes to bile salt or goes out in the bile. So that's why it's going to reduce, it's going to prevent the deposition of cholesterol in the peripheral tissues. HDL, good cholesterol, I mentioned to you. And the only one drug, there are so many anti-lipid drugs, only one drug which is really going to increase the HDL level is nicotinic acid or exercise. Nicotinic acid is the best lipid lowering agent to increase HDL. Do not, I repeat again, best lipid lowering agent is the one which we use for hyperlipidemia cases. But we, at the moment, we want to increase HDL. The best drug is nicotinic acid, which also known as niacin. Second is exercise. Dietary alteration are not very effective in HDL because HDL is concerned with why? Cholesterol. And dietary fat is triglyceride mainly. That's why dietary doesn't change much effect on HDL. What is the composition? Oh, protein 50%, triglyceride 3%, cholesterol 20%, phospholipid 27%. They are synthesized in the liver and the small intestine. They are the site of synthesis. So don't get confused where they are acting and where they are getting synthesized. Function is the low source of ApoE and C2. If you remember in the very basic, I told you that ApoE and C2 are getting will be source of what? Source of from HDL will come from C2 and will give you E, and C2 will come from HDL. They remove cholesterol from fatty streak and atherosclerotic plaque. What I told you, they are going to remove cholesterol from peripheral tissue and they will take to the liver. So now this cholesterol will be either secreted into bile or converted into bile salt and bile acid. The function I already mentioned to you. So friends, I hope you got a good input about the basic concept of physiology, biochemistry, and now the next part 3 and part 4 will be more of a clinical orientation. But unless you know the basic part 1, part 2, you will have difficulty in understanding part 3. But at the end of part 4, you will be master of lipid. So you will have no difficulty. And remember, lipid are considered as one of the most difficult topic in whole medicine. Thank you very much. God bless all of you.